Our client was Oliver Morehouse, a 3-year-old with cerebral palsy, microcephaly, hypotonia, and other diagnosed developmental delays. Oliver does not speak with his parents or caregivers in language. Instead, he makes vegetative sounds, vowel sounds, and uses his eyes to communicate with his mother to tell her what he wants. He doesn't sit or stand up alone, and he is unable to walk. The secondary SLP, PT, and OT all noted that Oliver has trouble attending to pictures and instructions whenever he's in therapy with them.
In order to assess Oliver's cognition, language, oral mechanism, articulation, and swallowing, several assessments were given. First, we used an AAC checklist to determine if an AAC device would benefit Oliver's communication, and if so, what type of device would be most beneficial. Next, we took a communication inventory to determine what methods of communication Oliver uses in his daily life. To test Oliver's cognition, we administered the HELP, or the Hawaii Early Learning Profile, and the age range was birth to 3 years. A clinical observation of Oliver's home environment was conducted to test if there was any dysphagia while feeding. The Rossetti Infant-Toddler Language Scale was administered in order to test Oliver's language. The results indicated that his interaction attachment equivalency was solid from 3 to 6 months, but scattered from 9 to 12 months. His pragmatics equivalency was solid at 6 to 9 months and scattered from 9 to 12 months. His gesture equivalency scattered up to 9 to 12 months. His play equivalency was solid at 3 to 6 months and then scattered up to 9 to 12 months. His language comprehension equivalency was solid at 3 to 6 months, then scattered from 9 to 12 months. And his language expression equivalency was solid at 3 to 6 months and scattered from 6 to 9 months. Oliver seeks attention from others, communicates non-verbally using gestures, and uses vocalizations and gestures to request food. He responds to no most of the time and responds to requests, "Come here." He shows some separation anxiety and shouts to vocalize to gain attention. He does not initiate social routines or produce 4 different syllables. He does not imitate consonant or vowel combinations. An oral mech exam was administered through the pediatrician. The results followed that the clinician prompted Oliver to imitate oral motor movements when looking in a mirror. However, Oliver was unable to follow the verbal or visual prompts. A tympanometry exam was administered, and his hearing appeared to be within normal limits. A pre-symbolic play checklist was also given in order to determine the ways that Oliver interacts with others and plays. Based on our assessments, we determined that Oliver would benefit greatly from an AAC device. We also determined that he has moderate dysphagia during feeding. He has dysphagia in the oropharyngeal stage, the pharyngeal phase, and severe feeding difficulties. It was also determined that Oliver has severe cognitive deficits and also deficits in his expressive, nonverbal, and receptive language.
Results from the standardized test assessments, coupled with Oliver's medical diagnoses, have a profound effect on his articulation, phonology, and overall language use, since Oliver is unable to talk or communicate nonverbally and verbally. We recommend that an AAC device be used. In order to begin conditioning Oliver for an AAC device, I will begin using picture cards that are printed off that use basic objects required in his everyday routines, such as a picture of a cup of juice that I would present during mealtime. I would begin conditioning him to use these and attend to these by pulling them out when they're most meaningful. So going back to the juice card, I would show him the cup of juice at mealtime, model the word juice to him so that he could hear it, and after a couple of models, maybe 3 to 5, I would present him with his glass of juice, so that he could learn not only to attend to the picture card, but the meaning and how important using a word and communication during something like mealtime is. Once I feel that Oliver is able to maintain his attention to the picture cards and their meaning about 80% of the time, I'll move on to asking him to use the picture cards and eye gaze in order to communicate with me. So, for example, I will present his picture cards at playtime. I'll have a picture of maybe his favorite toy, a picture of juice, and a picture of his mama, and ask him to show me the toy that he wants to play with. Hopefully, he will choose his favorite toy by maintaining his eye gaze and differentiating between the three pictures that I have presented. Once I feel that Oliver has mastered his basic pictures with about 80% accuracy as well, and is using those to differentiate and choose during things like mealtime and playtime, I will move to using the picture cards more frequently for less obvious things. So, for example, he'll use his cup picture with juice in it for when he's thirsty, not at mealtime. And he'll use those hopefully to communicate with the clinician and his family. And once he moves to using those 80% of the time, still with eye gaze, if his pointing and fine and gross motor skills don't allow for him to do that, then we will move to getting his AAC device ready. Once Oliver has mastered using picture cards presented by his caregivers and myself, I will move to prepare him for an AAC device by beginning with the Tobii Dynavox entry-level eye tracker PCI Explorer. And this will get him ready and conditioned to using an eye gaze type of AAC device to communicate on the computer, and it will allow him to communicate for the first time without the help of someone else. Hopefully he will master this, and once he masters this, then we'll move to the Tobii Dynavox iSeries Plus, which he will use in school and at home. Before Oliver transitions into school, I hope that he will be using the Tobii Dynavox AAC device to communicate most basic wants, needs, and thoughts with caregivers and other professionals and myself. And I will figure out whether or not he is doing this by my own observations and reports from parents and other professionals if I am unable to observe them. So once he is able to do that, it is my goal that he uses his AAC device to communicate his wants, thoughts, and needs in the school setting with 80% accuracy 80% of the time. Just like my data collection before Oliver began school, I will be able to understand if Oliver is using his device and how he is using his device through my own data collection, observations that I make while he is in the classroom setting, and any reports that I receive from other professionals or his teachers whenever I am not able to make it there. As Oliver ages, becomes more proficient with his device, and matures, his vocabulary will also need to mature. Therefore, the device will need to be modified during sessions as he makes strides and sees necessary. My rationale for choosing this treatment device for Oliver comes from the fact that he has shown no improvement in verbal communication skills, and his many medical diagnoses have been known to hinder or halt verbal language production. However, I understand that his mother would like to see him using some basic words to communicate. Therefore, I will not completely rule out verbal communication as I condition him for his AAC device. For example, I will provide modeling and give him opportunities to speak, as well as work on strengthening his oral muscles and motor skills. Since observations of Oliver show that he has difficulty in volitional control and motor movements, both fine and gross, I feel that he should use an eye gaze AAC device. However, this could change as I work with him and he grows and matures, but knowing his diagnoses, I think that the eye gaze AAC device would be the best bet for him. Oliver's difficulty in attending to tasks and holding attention to one picture has been documented by his mother and many other healthcare professionals who have seen him. For this reason, I wish to allot plenty of time to condition him in his AAC device training.
Because Oliver has a normal oral mechanism, articulation goals will be used in therapy. His mother also has personal goals for him in his communication, including using simple words such as mama, papa, hi, bye, and more. Before working on articulating simple words, we will work on strengthening the oral mechanism by doing many activities during therapy. These activities include blowing exercises, lip exercises, and tongue exercises. With blowing exercises, we will practice blowing bubbles or blowing a cotton ball across a piece of paper. With lip exercises, we will practice rounding the lips around a lollipop or moving things with our lips, such as a straw. With tongue exercises, we will work on pushing back a tongue depressor and pushing the tongue against different parts of the mouth. During articulation therapy, I will teach Oliver how to say simple words such as mama, papa, hi, bye, more, and all done, by starting off teaching him how to make certain phonemes that he does not have. I will start by teaching Oliver vowels that will be used in his daily vocabulary, such as the ah in mama and papa, and the I and hi and bye. Once Oliver has met the goal of producing vowels that will be used in his daily vocabulary, we will move on to consonant production, such as the and p sound. Once Oliver can successfully produce his vowels and consonants, we will then work on combining those vowels and consonants in simple CVC and CVCV words. While teaching him these words, I will accompany the verbal output with visual cues, such as a picture of his mom when talking about mama and a picture of his dad when talking about papa. While teaching Oliver articulation techniques, I will also be implementing the use of sign language along with his verbal language. So to start off with simple words such as mama or papa, I will say the word mama while also showing him the sign for mama. Likewise with papa, more, all done, hi, or bye. With this multisensory approach, it will be beneficial to Oliver because he might pick up one aspect of language quicker than the other. So he could pick up his sign language quicker than his verbal output or vice versa. If Oliver hits a plateau with his articulation or his use of sign language, then we will know that we have accomplished something that will help him and benefit him while using an AAC device. For example, if he is somewhere where he does not have his AAC device, he could still communicate his basic needs to those around him, especially his parents. By teaching Oliver how to articulate certain words, this will open up the communication between him and his parents. His mother noted that she just wanted to be able to understand when he needed something or was sick or upset, and by opening communication by the use of articulation and sign language, she will be able to do so. Because AAC training is so complex and it is also hard to condition children, especially with the use of eye gaze, articulation and sign language will greatly benefit Oliver's communication with his parents. Teaching Oliver how to articulate everyday words will lessen his and his parents' frustration with their lack of communication. His parents will be able to better understand his wants and needs and what he is trying to say, and he will be able to better express himself in ways that he has never been able to before. Due to Oliver's familial support, his prognosis is good. However, therapy could remain over the course of a few years in order for him to grow accustomed to the use of sign language, the use of verbal language, and the use of his AAC device. I am confident with the help of SLPs and his other therapists, Oliver will be able to communicate openly with his parents and others in the schools.